Hello, online students. I get to start recording for you Chapter 17. So if you do not have your MedSearch book out, if you would get that out, we're going to do a general overview of immunology, one of my favorite topics. So hopefully this is one of yours too, but if not, hopefully you will enjoy it. This is the last test for this time, so you want to make sure that you are studying as hard as you can. If you have any questions about anything, do not hesitate to get a hold of me. All right, so let's get started. And we'll start with the PowerPoint. Immunology lecture, chapter 17. Okay. All right, just a few hints. Make sure you look over your objectives carefully. Don't forget the theorist. Levels of prevention. Primary is always primary preventions when you try to prevent something from ever occurring. So examples would be immunizations. It would be car safety seat inspections. Secondary level of prevention is screenings. So anything that has to do with any type of early detection and screening is secondary. And tertiary is once something has happened, you go in and try to help them. For example, going into a rehab center, someone who's had a stroke. It's already happened. Now we're trying to make them better. Tertiary. So you want to remember those. Delegation. Remember who can do what. That's always on the exams. And then, of course, drug calculation. So if they're still giving you fits, you may want to give me a holler. All right, so what is the function of the immune system? Well, we all know that the immune system recognizes self from non-self. And anything that's recognized from non-self is considered an antigen and needs to go away. This is called self-tolerance in your book, self-tolerance. Thank goodness we do have things that will help us. We have an intact skin that serves as our first line of defense. We have secretions that also help, that contain certain chemicals that kill a lot of organisms that we come into contact with. And when your defenses of inflammation and immunity are working well, you are absolutely not sick, all your labs look well, you are considered or called immunocompetent. So I'm glad to know I'm competent at something. Biological defense mechanisms of the human body. Well, when we look at the components and responses of the immune system, the first thing that we look at is the lymphoid tissues or organs. The first thing is the bone marrow. Well, what do we know about the bone marrow? Well, if you remember, it is the source of all of our blood cells and our platelets. And what it produces is immature, undifferentiated cells called stem cells. So if you remember that, they're stem cells. In other words, they're not committed to become a specific type of cell yet. So usually it requires about 12 to 14 days for a stem cell to mature into something. So look on your book on page 277. And when you do, you're going to see there in figure 17-3 a stem cell differentiation and maturation. You can see there in the bone marrow we have stem cells. The stem cells may go one direction and become a T lymphocyte, may become a B lymphocyte. They may also become a neutrophil, a basophil, a eosinophil, monocyte, or a red blood cell or platelet. So depending upon what your body needs is what that stem cell is going to grow up to be. And it's going to take about 12 to 14 days to do that. Okay? So that helps keep our body in homeostasis. Lymph nodes. Well, we all know that they can be normal or enlarged in a child, particularly in a child who's had repeated infections. It's particularly that deep cervical chain. Once they turn their neck, it may pop out like popcorn if they've had a lot of infections. You always want to make sure they're movable, painless, and that they do have a history of some type of infections. Usually that's benign. If they are not movable, they're painful, and they really haven't had a lot of histories of infections, then they definitely need further follow-up. That is a need for a red flag alarm. Okay. We know that they function, lymph nodes, to filter foreign material. They're located in our inguinal, axillary, cubical, neck, and abdomen areas. The thymus is next. The thymus is the master gland. And what is the master gland of? Is stimulation of the immune response before puberty, and then it monitors the lymphoidal system thereafter. So it's very large at birth, or thymus, and then as we begin to age, it begins to atrophy by about puberty. Now, it's located in the upper mediastinum under your sternum, and that is where your T lymphocytes mature. That's very important to remember, because as we get older, then, if that is getting smaller, it's not working as well, then we won't have as good a production of T lymphocytes. Then you have your spleen. Your spleen, we know, is an encapsulated vascular organ that's about fist size in your upper left quadrant of the abdomen. We know there's the red pulp and the white pulp, and it's the only lymphoidal organ that can filter blood. Very important to remember. Then you have what's called the GALT, the gut-associated lymphoepithelial tissue. And this would be things like your tonsils, your adenoids, your appendix, that also help in different systems, particularly fighting infection. Number 2, the second component is the mononuclear phagocytic system. These are what we call the cell eaters, anytime you see phagocytic. And this would be your monocytes and macrophages. Now, your monocytes we know grow up to be macrophages, or macrophages, however you learn to say it. So monocytes circulate in the blood, doing their own thing, until they see something that needs to be taken care of, and then they will develop, swell up like Pac-Man or macrophages, and they'll rid the body of those worn-out cells and other debris by gobbling it up. Okay? Now, the thymus and the bone marrow are the two primary organs. All these other ones we have listed here are secondary. The major biological defense mechanisms, well, we got natural defenses, inflammatory responses, and then specific acquired immune responses. And we'll talk about each one of those. First, your natural defenses. This is the first line of defense. This would be like your skin, your mucosa, your respiratory tract, digestive, GU tract, and your eyes. Well, how are these natural defenses? Remember I said earlier that we have lots of chemicals in our body that help take care of organisms. Well, a lot of these, depending on when we're talking, for example, the respiratory tract, we know has ciliated epithelium, has mucus, has antibodies, particularly IgA, and it has phagocytic function. So all those things are going to help when you come into contact with bacterial infections, viral infections. The eyes, we know there's enzymes in our eyes that helps tear, so that if we're tearing a lot, we'll help washing out certain things. So that would be some examples of how we have natural defenses. The second thing is our inflammatory response. This is our second line of defense if it gets past our first line. And here we have a series of physical and chemical reactions that result in the classic signs of, and rubor means redness, calor means warmth, tumor means swelling, dolor means pain or itching, and then loss of function can also affect this. So we all know that redness, warmth, and swelling, along with pain, is an inflammatory response that something's going on and our body's reacting to it and trying to get rid of it. This level of response is nonspecific. It is stimulated by cell injury or infection, so that we have both intrinsic and extrinsic causes that can bring this on. Now, infection is usually accompanied by inflammation. However, inflammation can occur without infection. For example, a sprain. Physical events that are responsible for the inflammatory response, we have vasodilation, increased capillary permeability, and the arrival of white blood cells to the scene, particularly the SEGs, being your neutrophils, and your monocytes that are in the blood that grow up to be macrophages in the tissues to get rid of different debris. Vasodilation, when you think about that, anytime something dilates, it's going to increase blood flow. Well, if I have increased blood flow to an area, I'm going to have that redness occur. There's our rubor and our warmth, our calor, because of the increased blood flow. That also increases the number of neutrophils to the sites. That would be your bands and your segs. So once we have an increase in neutrophils, that's going to increase the supply of antibiotics eventually. Antibodies. Number 2, increase capillary permeability. Well, if you increase capillary permeability, you're going to allow things to come across barriers that normally would not. So you're going to have swelling that results to more, and the pain, dolor, that's going to follow the swelling. So that's where these signs and symptoms come from, because of the vasodilation and the increased capillary permeability. Now, the third thing is the arrival of white blood cells on the scene. Now, I think of them coming on the scene of an accident to chew up debris. Your segs are always your mature neutrophils. Remember, they're the mature, and your bands are the immature. Of course, they're going to arrive there first, get there very quickly, about 5 minutes, and there's a 7-day supply built up in the bone marrow of mature neutrophils or segmented neutrophils, okay? Now, in a immunocompetent person, remember that's someone who's healthy with no immune problems, there are more than 100 billion fresh mature neutrophils that are ready to be released from the bone marrow daily. So you can see why it takes an overwhelming acute infection to deplete that blood, to deplete that bone marrow from neutrophils. Unfortunately, each neutrophil is on a suicide mission. Once they go, they do their thing, they get one shot, and they're gone. Also, the monocytes, again, remember they grow up to be macrophages and like Incredible Hulks or the Pac-Man and become about 5 times their original size. And they engulf the larger particles and even the dead neutrophils. They keep things very neat and tidy. And the liver and the spleen contain the greatest concentration of tissue macrophages. If you don't remember shift to the left versus shift to the right, you might want to go back and review that. Now, is there advantages of having pain and swelling, tumor and dolor? Of course there are. Pain, we know we don't like it. We know when we touch something hot, but it increases our awareness enough to say, remove your finger from this hot stove. It is burning. So that helps prevent further injury. Swelling. Swelling creates actually a cushion of fluid that protects that area that's been injured from further injury, and it also can dilute the concentration of toxins and pathogens. So even though we don't like pain and swelling, there are definitely advantages to pain and swelling. So what are the chemical events then of inflammatory response? Well, we've got mast cells that are located throughout the body, and these cells contain histamine. And when histamine's released, we get vasodilation, increased vascular permeability, and increased secretion of nasal, bronchial, and gastric glands. Activation of the complement system occurs. And the complement is a series of 11 inactive proteins in your serum that combine with antigen antibody complexes to produce lysases. So, in other words, antibodies can't produce cell lysases. They can't go in and break down the cell of a bacteria. So they take a complement along with them or a recruit to join in the reaction. The third thing is specific acquired immune response. This is our third line of defense. This involves both humoral and cell-mediated immunity. Humoral response is antibody-mediated immunity, so AMI. So anytime you see humoral, think antibody-mediated. And that involves B lymphocytes. So that's responsible for our initial response to any antigen that we've come into contact with. On the other hand, cell-mediated involves your T lymphocytes. And you'll remember those are thymus derived up till puberty. There are 3 types of T lymphocytes. We have the T4s, and those are very important to know about because we're going to talk about those. Now, they have been recently renamed to CD4. So when you see CD4, that's a T4, same thing. The big thing that they do is they are helper cells, so they turn on the immune system. Now, suppressor T cells, or T8 cells, turn off the immune system. They're also called CD8 cells. Cytotoxic T cells, or killer T cells, known as T3 or CD3 cells, release toxins to destroy pathogens. So these are your 3 most common you're going to come in contact with: CD4, CD8, and CD3. Now, there usually is twice as many of these helper cells as there are suppressor cells, which is a good thing. We want twice as many aboard that can turn on the system than off the system. Now, what happens in HIV and AIDS, which we're going to talk about, is it attacks CD4, T4, CD4 cells. Those were the helper cells that turn on this immune system. So if it attacks these cells, then you end up with more T8 cells that turn off the system. That's why they become immunocompromised and immunosuppressed. All right. Actually, immunocompromised. FYI, the initial immune response takes anywhere from 7 to 21 days and is known as the primary response. So anytime you come into contact with something, it takes about 7 to 21 days to build up a primary response. Now, we all have memory cells, thank goodness, that say, hey, I remember you last time you were in the body, and I developed an antibody to you. So my response to you this time is going to be a lot quicker, and I'm going to get rid of you pretty quick. And usually only takes about minutes, 99% of the time. Now, there are factors that affect the immune response. Age, emotional stress, physical factors like nutrition, and hormonal influences like females having a higher incidence of autoimmune disease. Now, when we think about age, remember the thymus gland that we talked about earlier, where the T cells, T lymphocytes go to mature. That's going to deteriorate with age then. So your older clients are not going to be capable of producing mature differentiated lymphocytes. So they have an increased immature lymphocytes in their circulation. So they're going to have slower response to any kind of infection. It's going to take them longer to get over it as compared to someone who is not very old or not very young. Now, emotional stress. How does that affect our immune system? Well, it affects your cellular immunity because when T cells respond to antigen, and when you take those T cells and they're measured in people who are grieving, the results always show a decreased response. So it decreases the response of your T lymphocytes. Now, we all know about the physical factors, nutrition affecting immunity. If you've been in the hospital and, your immune system's weakening down and you're not also taking in protein for healing and milk products and calcium and other things that you can lead yourself into further complications. Okay. Now, what are the general principles of immunity? Well, the first thing is to recognize self versus non-self. Remember, we talked about that earlier, self-tolerance. Some of the ways we can do that is from what's called an MHC, which stands for Major Histocompatibility Complex. And that produces molecules marking the cell as self. So I've got a cell out here, and I've got little things around it called MHCs. Now, the markers that are on there are actually referred to as Human Leukocyte Antigens, or HLAs. Okay? So we know that the complex produces molecules marking a cell as self, and then it's actually called HLAs. Now, where HLAs are very important is they're like a tissue printing or a tissue typing or a fingerprint. So there's about 40 major ones, and there are several minor ones. And there's even some HLAs that are unknown because there's just so many HLAs out there. But if an HLA marks a cell as self, then you can see where we have a lot of people that have transplant rejections, tissue rejections, organ rejections. But if these HLAs are not matched up perfectly, so you've always said, we've got someone who needs a bone marrow transplant. We want everybody to come down and see if you're a perfect match. Well, what has to match is these HLAs. If they don't, the body will see that as non-self, and it will turn on that new organ, new blood, whatever it is that you have gotten. Blood cells, blood marrow, bone marrow. Specificity is the ability to recognize millions of distinctive non-self molecules and to match them up and counteract them, each with their antibody that will destroy them. So that's very important. Also, memory cells are important because it prevents you from getting a lot of the same diseases twice, or it keeps you from, it makes you heal a lot quicker the second time if you do. Now, there's a few oddballs out there that get things twice. Yes, I know some people that's had chickenpox twice or measles twice. Again, there's just some oddballs out there that do that their memory cells just poop out and don't work quite right. All right, review of terms. An antigen is any foreign substance that elicits immune response. Okay, and an antigen is any foreign substance that elicits an immune response. Antibodies are protein molecules known as immune globulins, which are present on the cell membranes of lymphocytes and that protect the individual by attacking the antigen. Okay, so an antibody attacks the antigen. Now there's 5 different types, each with different structures and functions. I have had the fun of naming these. IgG, the giant. That means they're abundant. IgM, moose, the gang members, because they hang out in clusters of 4 to 5 and watch the surveillance of the blood system to make sure nothing's coming around. IgA, sweet Andrea. She lives in the breast milk, the respiratory tract, and helps protect us from infections, particularly viral. IgD, duh, what do I do? And then IgE, Big Ed. Big Ed is our construction worker, and we'll talk about why we've called him the construction worker here in a little bit. You think this is silly, don't pay any attention to it. Just remember IgG, M, A, D, and E. These are just easy ways for me to remember them. IgG, the giant. Okay, this is our all-purpose antibody. It's our most abundant. It's the one that's commercially available, that when we give infusions of immune globulin, we're primarily given IgG. It is one of the 2 major antibodies found in the serum. Greater than 75% is just IgG. It has very long-term memory and is the only one that crosses the placenta. It also helps activate the complement system. What was the complement system? Remember, we had to have a complement system, where a complement that went along with an antibody to perform the lysis, because sometimes they can't break into the cell. So you want to remember that. They're not the only one, but they're the primary one that's responsible for activating the complement. Some of these others are as well. So IgG, the giant. IgM, moose, the gang member. Moose is the major antibody found in the serum, another major one, 8 to 10%. It hangs around about in groups of 5 and clumps together to kill bacteria. So it's the first antibody formed to an infection. It protects the neighborhood. So it literally goes around in the bloodstream, clumps of 5 looking for things to attack. It also helps activate the complement system as well. Now, when you look at moose is the first antibody there. The first white blood cell there is your neutrophils. So MN in the alphabet, moose gets there and neutrophils get there. MN. That's an easy way to remember it. IgA, Andrea. She is mainly found in the blood secretion of our tears, our GU, our GI secretions, our respiratory, and our breast milk. She's responsible for about 15% in the plasma. Breast milk, IgA, plays a major role, we know, in the immune system of infants who are breastfed. They do not get as many allergies, particularly asthma. They do not get as many viral respiratory infections because, again, she lives in the respiratory tract, so she helps fight those. So another reason to breastfeed. IgD, what do I do? Well, the role is not well understood. We know it increases during chronic infections, and there's only trace levels found, only less than 1%, so we're just not really sure what IgD does. IgE, Big Ed. Well, Big Ed is found mostly on the mast cells in the skin and the connective tissue spaces, and only trace levels in the plasma, again, less than 1%. What Big Ed does is drills a hole in the mast cell. So it gets on top of a mast cell with his jackhammer-like system and drills a hole. That releases histamine into the interstitial spaces. So Big Ed is always involved in allergic disorders. So anytime you see someone who's got a lot of allergies, IgE is going to be up. Asthma, IgE is going to be up. Okay. The immune system is the most efficient when people are in your 20s and 30s. After your 30s, the whole immune system, even your antibodies, start declining. Not good news. All right, so if you don't understand anything about the antibodies, let me know. Just a quick review so we don't forget from childhood infections. Types of immunity. If you'll remember, active was long-term immunity and passive was short-term immunity. You may see some terminology like innate, native, meaning natural, or adaptive, meaning active immunity now. So they may be changing some of the terminology up. So anytime you ever see adaptive, it means active. If you see innate, native, it's natural. So if you see artificially active, which one of these would it match up to? If you see artificially passive, Which one would it match up to? Naturally active and naturally passive. So I didn't try to pull any tricks. Artificially active went with immunizations. Artificially passive, immune globulin administration. Naturally active, chickenpox is an example. And naturally passive, transplacental. Okay. There are 4 primary immune system malfunctions we're going to be talking about. The system can overreact, so you get a hypersensitivity reaction. We'll be talking about the 4 main types of hypersensitivity reactions. The system can overproduce, that's covered in oncology, where you get a lot of your gammopathies. And then the system applies its normal function to self, so it turns on itself, autoimmune disorders. And then the system does not function adequately, immunodeficiency disorders, which we'll be concentrating most heavily on. Nursing care of the immunocompromised patient. Remember, there's going to have to be maintenance of their normal defenses like the skin. So we want to protect skin. We want to protect mucous membranes. If someone is immunosuppressed, we don't want to be doing rectal temps and suppositories. We want to do everything to prevent trauma and infection from occurring. Also, you want to make sure to give them good hygiene and adequate nutrition. Decreased risk of exposure to infection. Environmental, routine cleaning will help eliminating stagnant water. We know that harbors infection and bacteria. Personally, screening their visitors, doing good hand washing, preventing cross-contamination. Procedural-wise, you want to do aseptic technique and minimize any kind of invasive procedures. For monitoring for signs of infection, of course, you're going to be monitoring vital signs, changes in level of consciousness, and any signs and symptoms of infection that you can visibly see. So let's review the CBC. I know y'all have had hematology, but it never hurts to review, I've learned. Granulocytes, these are your phils. So these are your neutrophils, your basophils, your eosinophils, okay? Your neutrophils make up 90%. These are your bands plus your segs. They're the first ones called to the site of infection along with IgM. So remember, MN, IgM, moose, and the neutrophils are the first ones to get there. The basophils are responsible for any time you'll see a count go up if there's some inflammation or someone who's had an anaphylactic reaction. And remember, the eosinophils only go up during 2 times: allergic reactions and worms, parasites. So if you've got someone who comes in with a very high eosinophil count, who has not had any kind of allergic reaction, who does not have any kind of allergies or asthma, you might want to do an O&P. Okay. CBC review count, A, granulocytes. A meaning without. Anytime a word has A in front of it means without. These are your cytes. So your monocytes, who we know is in the blood, who grows up to be macrophages in the tissue to destroy or clean up. Lymphocytes can be T and B lymphocytes, right? All right, so we never let monkeys eat bananas. That's the order and decreasing that we see them in the actual count. Remember, I gave you some rough hemoglobin and hematocrit norms, platelets 150 to 400, white blood count 4,500 to 11, and you may see 5 to 10. Again, all books are different. But your segs and your bands, segs being mature neutrophils, bands being immature or stabs, same thing. The matures make up 55 to 70%, the immatures 1 to 7. So you come in, your bands are 10%. What does that mean? Remember, these are your immature. So you've used up every one of that 7-day supply of these mature ones because you had an overwhelming acute infection. So you have a shift to the left because you have an increase in your immature bands. Lymphocytes make up 20 to 45%, very common with viral infections. Monocytes, eosinophils, and basophils. So we never let monkeys eat bananas. Then that's the decreasing order that you will see them on the count. Neutropenia, anytime you see the word penia, think decreased. Penia, decreased. Penia, decreased. Decrease in neutrophils. Immunocompromised. You always want to look at the white blood cell count to see if they are immunocompromised. Lymphopenia is immunosuppressed. Look at the T cells. That's why I said earlier when we were talking about AIDS, I changed it and said they are immunosuppressed. Sometimes it does not affect their neutrophil count. Sometimes it does, depending on what's going on with them. So they may or may not be immunocompromised, but they're always going to be immunosuppressed. Why? Because remember, HIV attacks the CD4, which is a type of T cell, so that turns the system on, so they make them become immunosuppressed. Remember the formula for figuring absolute neutrophil count. In case you've forgotten, it's the white blood cell count total times the segs plus the bands divided by 100. Anything less than 1,000 means they're neutropenia. Penia means decreased amount of. But less than 500 is life-threatening. Okay, any kind of infection could kill them. And 1,500 is really considered mildly neutropenic. What was neutropenic precautions? Remember, know your signs of infection. Anything sometimes with their immune system's way down. When I mean fever, I'm talking about 100.6 or higher. Could be fever, considered high fever for a neutropenic patient. They're going to be getting blood cultures, sputums, urine cultures. You want good hand washing, reverse isolation in a private room, screening the visitors for cold and illnesses. Skin care, neutropenic diet, raw fruits and vegetables are out because they can harbor bacteria. Stagnant water, particularly those in flowers, can harbor bacteria. They're out. If they're going to leave the room for something like an x-ray, you always want to put a mask on the patient for protection. Okay, so that's just a review of some stuff for neutropenic precautions. So that's the end of this section. Just a review to see if you remember any of these. Think through this as I'm asking these questions. The lymphoidal tissue in which the T lymphocytes mature. You should have thought thymus. The only lymphoidal organ that can filter blood. You should have thought spleen. The three major physical events responsible for the inflammatory response. You should have thought vasodilation, increased capillary permeability, and arrival of white blood cells to the scene. What's the first white blood cell to arrive to the scene of an infection? Remember, it's the neutrophils. When they're the most abundant, never let monkeys eat bananas. And it's usually the mature ones that go, the segs. The white blood cells of chronic infection, this would be like your monocytes that grow up to be macrophages. So if you see them up, why would they be up during chronic infection? Well, they're having to stay constantly on board and because they're going around eating up all the dead debris, including the dead bacteria. So the count's always going to be up during chronic infections. What's the chemical released by the mast cells? You should have thought histamine. What's the inactive protein which ruptures the cell membranes to complete the action of an antibody call? You should have thought complement. Which lymphocytes are responsible for the humoral response, sending antibodies? You should have thought B lymphocytes. Which of the T lymphocytes are the chief orchestras of the immune system and turn it on? You should have thought CD4 or T4 regulatory T cells. What's the group of genes on the major histocompatibility complex that mark the cell as self? You should have thought HLA, Human Leukocyte Antigens. What's the all-purpose antibody found in the serum that's the only one that crosses the placenta? IgG. What's the first antibody formed to an infection? IgM. What's the antibody that plays a major role in the immune system of a breastfed infant? IgA. What's the antibody that releases histamine from mast cells? Big Ed. IgE. Okay? So if you remember things like that, then it will help you on this exam. I know that you can do well. Just be determined that you can do well. If you got any questions or concerns, please don't hesitate to let me know. Thank you.